Good afternoon, everyone. Welcome to the Bermuda Healthcare Forum webinar. This is a slightly different format than what we'd hoped for, but we are happy to join you nonetheless. I'm Kim Morgan, Senior Vice President, Bermuda Healthcare Practice Leader at Sompo International, and I have the pleasure of joining you today on behalf of the Bermuda healthcare market. I would like to specifically thank the Bermuda Business Development Agency, the BDA, and the rest of our sponsors whose names you'll see on our title page for enabling us to present to you today. While the audience will be muted, we'd like to try to make this as interactive as possible, and therefore please submit any questions you have via the Q&A function, and we'll try to address them as we go. We will also be recording this and we'll be providing it to those participants who are registered afterwards. So it really goes without saying, we wish we were hosting you here in Bermuda this year, particularly given the sun is shining outside, rather than having to postpone yet again due to COVID. However, having now had a year of virtual meetings with so many of you, we thought it would be a good opportunity for a touch point where we can discuss some of the common themes our clients are facing. Understandably, so many of our clients' meetings have been dominated by discussions around our clients' own experiences with COVID as they try to manage the clinical, social, and financial challenges. Yet while it has negatively impacted so many, it is also evident that it's also positively accelerated change, not only in how care is delivered, but also in terms of what is needed from hospital leadership to ensure strategic success in 2021 and beyond. To help lead this conversation, I'm pleased to be joined by Dr. Rishi Sika, President of System Enterprises for Sutter Health in California. Rishi has executive oversight for a broad range of services, including facility and property services, health plan partnerships and products, lab services, mental health and addiction care, pharmacy services, Sutter Care at Home, Sutter Surgery Center Division, Sutter Walk-in Care, and Sutter Shared Services. He has also led the establishment of Sutter Population Health Services, a division focused on further improving care, quality, service coordination, and care consistencies, and reducing total cost of care. He was previously at Advocate Health in Chicago, where he served as Senior Vice President of Clinical Operations, which is where we first had the pleasure of working with him. Prior to that, he held clinical and management positions in emergency medicine at Advocate Christ Medical Center in Oak Lawn, Illinois, and at Boston University Medical Center, as well as faculty positions with the University of Illinois School of Medicine and Boston University School of Medicine. Earlier in his career, Rishi co-founded Cambridge, Massachusetts-based Praxian, Inc., which develops healthcare and life sciences semantic searching platforms to offer health information to patients, clinical practitioners, and medical researchers. He has earned his bachelor's degree in economics at the Wharton School at the University of Pennsylvania and his medical degree from the Mayo Clinic Medical School. He is co-author of the book, Leading Healthcare Transformation, a primer for clinical leaders, and has written for the Wall Street Journal and Harvard Business Review. Welcome, Rishi.
Hi, good morning or good afternoon, Kim. Great to see you.
Thank you, likewise. Perhaps before we start straight into the questions, you could give us some insight into your rather unique role in terms of really what you do and why that specific role was created.
Yeah, thank you. And thank you to you and the Bermuda Healthcare Forum and the Bermuda Business Development Agency for hosting this event and for giving me this opportunity. And thank you all for attending the webinar. It is a very unique role. I started here just a little bit over 4 years ago, and I think there was some prescience on the part of our CEO, Sarah Krevins, into creating this role about 5 years ago. And I like to think about the role in two parts. I oversee all of the non-clinical businesses of the organization and all of the asset-light clinical businesses. So all the non-clinical businesses of the organization, it includes our shared services organization, our facility and property services. It includes our health plan. We have a commercial HMO health plan. We have a joint venture with Aetna in the PPO space. We have a co-branded relationship with Alignment Health in the Medicare Advantage space. So it includes all of our non-clinical businesses, and then it includes our asset-light clinical businesses. Really, most of the stuff that is outside of the hospital environment. Our surgery center division. We have 34 surgery centers, and the vast majority of those are joint ventures. We have retail clinics, over 25 walk-in clinics in our footprint. It includes home health, hospice, infusion pharmacy, mental health, pharmacy, lab. And I think the idea is by taking that sort of non-clinical piece of the organization, I think in particularly our back office and our health plan, and being able to combine that with these asset-light, lower-cost delivery alternatives, is there a way to bring that together into a portfolio to deliver not just on quality and access for the market, but also at a lower price point for the market as well, which is such an imperative in United States healthcare. I think it's also a vehicle that allows us as an integrated delivery system to compete against probably what is our newest or most formidable competitor in the form of vertically integrated health plans as well. So hopefully that gives a little bit of background or a little bit of method behind the madness. Otherwise, it kind of seems like it's just a long list of things that maybe other people didn't want to oversee.
I understand, in addition to all of these responsibilities, you may have recently donned your scrubs again.
Yeah, I did. I think I put the clinical piece on in two respects. You know, going back a year ago, obviously we've been managing the pandemic, and I was one of the first several months, one of 4 incident commanders helping to manage the pandemic. We were rotating on and off every 5 to 7 days. And then I did get back into clinical medicine and have been vaccinating for the past 2-3 months, done several shifts vaccinating our employees, which was just a tremendous experience, just so much joy and hope in our employees and our physicians as we were rolling that out back in January. And I've been vaccinating patients at our mass vaccination clinics as well. And it's been good to be in that environment and reconnecting with patient care and patient delivery. But both really great experiences to be back on the front line.
Great. So if we sort of roll back to last February, March, we were meeting with a lot of our clients. Hospitals were beginning to stand up their incident command centers for COVID. I believe you were one of the incident commanders. Can you sort of help us with some insight into what that experience was like?
Yeah, that's a great question. It was sort of a double-edged sword in some ways. It was obviously extremely intense and always on. I remember a couple times I would be driving in very early in the morning to our incident command center, which was located here, and just a flurry at 6 a.m. of text messages and phone calls of urgent requests for supplies or materials or issues that were going on. There was definitely an intensity, and there was definitely an intensity in our care environments, and a lot of kudos and gratitude to all of those, not just in our organization, but honestly throughout the globe that have been at the point of care for this pandemic. I say that the double-edged sword, if you want to say what was the silver lining in this whole thing, is that there was just almost a gift of clarity and focus, Kim, that was not just within me or the other incident commanders, but throughout the organization, of just having absolute alignment and understanding of what needed to be done and the straightest path to get there. So while there was all that stress and intensity, and some of that is still lingering and it's real, there was also very much that gift of clarity and focus that was also during that environment and during that time. But happy to go deeper on any other aspects though, to probe.
I know from our perspective, when this all began, we were all sort of wondering, how prepared are our clients? We've been hearing quite a lot about their own journeys with Ebola back in, I think it was probably 2014. And everybody seemed pretty bullish, quite honestly, kind of going into this, that, they were well prepared. I don't think, in retrospect, I don't think anybody really realized what was coming.
Yeah, I think you're absolutely right. I served as the incident commander back in Advocate during our Ebola preparedness efforts. I guess that was several years ago. And I know this organization had also had similar preparedness efforts. I think the extent of the contagion and the transmissibility of the virus, the unusual presentations and the unusual complications that came from the virus, and it's just affected a significantly broader swath of the population than could have been anticipated. I think this was compounded by, I would say overall lack of healthcare infrastructure preparedness in the United States, particularly with respect to testing and PPE. And that had downstream effects then on staffing and certainly issues of stress as well within the workforce. I think all of that kind of contributed in a perfect storm. We used to say a year ago, there were like just 3 things we were focusing on every single day. It was testing, it was PPE, and it was staffing. And it was that triad that was the overwhelming focus.
Yeah. I think probably one of the most common themes that we've been hearing has really just been this transition to a virtual care environment. Many of our clients, have had, differing means of telemedicine for some time now. But without a doubt, we're hearing, clients who've gone from, hundreds of visits to multiple thousands of visits in a 3-month period. How much do you think we can effectively do in a virtual environment? And do you think it's really here to stay?
Yeah, great question again. So, at the start of 2020, before the pandemic, we were like casting this 3 to 5 year runway to get to the required number of virtual visits that we wanted to see as an organization. And COVID was just this profound accelerant for good things and for bad things in our environment. And we went from doing, Kim, about 20 visits a day at the height of so that was before the pandemic, 20 visits a day at the height of the pandemic, and we were doing 7,000 video visits a day. Now that's fallen to about half that. And I think that's going to show, and it's been about half that now for quite a bit. So I think that's going to seem to be the steady state. That half number, that means about 10% of our visits, and that's not including radiology and things like that, but our core clinical visits, about 10% of our visits are now conducted virtually. I do think it's here to stay. I think it's here to stay for a couple of reasons. One is that patients are comfortable with it and they've gotten used to it. And quite frankly, they like the convenience of it, of not having to drive and deal with traffic and parking and those pieces. I think the other reason it's here to stay is that our physicians have gotten used to it. Certainly there's limitations to what can be done on video, but the history taking is just so core in the patient interaction. It's probably the most revealing part, quite frankly, at least in my experience, from my specialty's experience, that physicians have gotten extremely comfortable with it. And then the last reason why I think it's hopefully here to stay, cross your fingers, is that the reimbursement was there for these visits. Now, I think there are some challenges on that some of those waivers need to be made permanent. There's issues with self-funded employers providing reimbursement, but it's been really a great experience. I'll tell you something interesting that we've learned is that with the virtual visits, the no-show rate has dramatically changed. I would say on average, our no-show rate was somewhere between 15 to 25%, depending on where and what service. And with the virtual visits, that no-show rate is like less than 5%. Particularly dramatic, by the way, in mental health, if we have a chance to go deeper on that.
Yeah. And we can head there now. I mean, just the, you touched earlier, just sort of, there's just this feeling of a lack of public health infrastructure. And, our health system's now really becoming the de facto public health system.
Yeah, I think that has been a unfortunate consequence or learning during the time of the pandemic, is that there has been probably a systemic underinvestment in the public health infrastructure of the United States. We saw that with respect to the PPE issues. The national stockpile didn't really have the PPE that we thought we could have. We did not have the domestic either sourcing or production capacity. I say sourcing raw materials, production capacity to generate PPE. Even if you look at what we're doing with vaccination right now, I think it's a great case in point. This vaccination program is truly a textbook public health intervention. I was referring to it back in January when it was a little more topical, that the COVID vaccine was quoting somebody else, is the Super Bowl of public health. The Super Bowl is at the end of January in American football. And, that Super Bowl of public health, integrated delivery systems have been bearing a significant portion of the responsibility to deliver that, because the public health infrastructure is not available to deliver mass vaccinations. We are running 10 to 15 mass vaccination clinics. We have the capacity to do over 60,000 vaccines a week. We have vaccinated we have provided over 500,000 vaccinations between the public and our employees, but that's not necessarily our core business, but we have had to now step into that vacuum out of necessity, and in some cases out of requirement. It's something we can't do alone. We do need to do that with partnerships, not just with the government, but also with other organizations in the community. And mental health is obviously another core. I used vaccination. I know we started this dialogue going on mental health, but mental health is also an area we cannot solve alone as an organization. Mental health challenges.
Yeah. And then just in terms, we're also hearing a lot, for this public outreach, and it's even, with the vaccinations, but really going into the community, going into sort of some of the churches, some of those other areas, really just to be able to support those who otherwise are somewhat lacking in access to the care.
Yeah, I think there's to build off that, I think there's two big themes there. One is partnership, absolutely. And then the other one is competition collaboration. Let me just talk about both of those for a second. So the partnership, we can't do this alone. We can't do any of this alone. We have partnerships with health centers and community organizations, and we are doing specialized outreach with special dedicated locations for that outreach for underserved or vulnerable communities in our area. Again, that's something we have to do together with the broader community. We're in the not-for-profit. We are a not-for-profit organization. We serve the community, so that's been a great reinforcement of our mission. We are actually just about a week or two ago started a pilot where we are doing vaccinations for homebound individuals through our home health organization. Again, that's another way of delivering to vulnerable populations in partnership and with the community. So clearly partnership has been another part of it, has been a part of it. This idea of holding two opposing ideas of competition and collaboration. There are organizations here in Northern California that we compete with, other hospital systems, other organizations. But during this time of the pandemic, we aren't just competitors, and we hold that thought, if you will, for a second. We're also collaborators and helping each other. There have been many times when we have reached across the aisle, so to speak, and needed help with testing equipment or supplies or vaccine. And there have been times when they've reached out to us for that kind of help, and we've obliged. So that's also been a new theme, I think, during the pandemic, of competition and collaboration. And I hope it's one that's going to persist in the time ahead, because we're going to need to do that, holding those two opposing ideas of competition and collaboration if we're going to solve some of the fundamental problems in US healthcare, and also deal with the lack of probably public health infrastructure.
And I would also venture to say, I mean, probably collaboration as well with others on supply chain. We touched briefly on PPE. I think previously health systems have sort of kept inventories rather low. With what we've been through recently, I think that's going to require a fundamental shift in sort of how we have historically looked at supply chain.
I think you're absolutely correct. I think our industry, like many industries, got used to, exactly as you said, Kim, of keeping days on hand or stock low as keeping your inventory turns high. It's a appropriate cost mitigation or an appropriate way to manage your cash flow to do that. But I think what we've learned is that in order to have an environment of preparedness with something which we have never encountered, certainly in the modern era, that we're going to need to keep many days and, quite frankly, weeks and months of supply on hand, and have lower inventory turns in order to be prepared. Again, because there was some of that lack of both public health infrastructure, and then the lack of domestic sourcing and production of the material.
Are you able to share sort of some of the efforts that you went through at Sutter?
Yeah, we had our supply chain team working. I'll be honest with you, Kim. We started sourcing at the end of December, early January, when we had this sense that what was occurring at the time in China would probably inevitably make its way to the United States. And I would say that wasn't just confined to PPE. We started sourcing ventilators actually back in January, just as an advanced measure, which proved to be, I think, fortuitous in that regard. We had our team, we had our team working 24/7 around sourcing around the globe from any lead that anybody gave us to find PPE. We had several instances, Kim, where we had PPE that we had ordered and actually from overseas. It was actually in the port here, I think it was in LA, and was seized and held by the federal government, and then redistributed to other organizations. I mean, like things that we absolutely needed so critically. We were fortunate. Well, another piece, we relied on local 3D printing companies or people who had 3D printers to do the face shields for us. We were working, and the supply chain team, I give tremendous credit to them. I do oversee supply chain. The tireless efforts behind the scenes to keep our staff, to keep our physicians safe, and ultimately our patients safe was almost heroic in some ways as well. But it was a tireless effort. I would say we got into a much better place with that towards the end of spring, early summer, where we were able to now get consistent sourcing of supplies. But we I gotta say, we still sweat it out a little bit. I know it sounds crazy, but that whole thing that happened at the Suez Canal a couple of weeks ago, I say that whole thing, where there was the ship that had run aground and there was blockage in the Suez Canal. We were concerned about what impact it would have on our supply chain for the organization. I think that's another sort of question on supply chain is, we are so globally interconnected. Is that a vulnerability? And does there need to be more domestic? Well, I guess, do we need a more diverse supply chain? I think you lose out a little bit on pricing ability when you have a more diverse sourcing base. And then I think secondly, do we need shorter supply chains and more domestic manufacturing, domestic raw material and domestic manufacturing capacity? So those are probably bigger policy questions I think the industry and frankly the United States is going to have to deal with.
Now, sort of switching, we've kind of been touching more on clinical side of things. If we switch a bit to more of a strategic financial view, financially, 2020 was just so challenging for our healthcare providers. Patient volumes dropped over 50% during the COVID peak. All the while, the providers were sort of on the front line. Hospitals were incurring even higher costs in securing PPE and additional staff. It has had a significant adverse impact on not-for-profit health system margins that were already thin. Does this current business model work in your view? What are we going to need to do to face this?
I think there's two aspects of the business model that weren't commenting on. One that was very apparent, as you're alluding to, and one that was perhaps lurking a little bit under the surface. The one that was very apparent, excuse me, the one that was very apparent is that for not-for-profit healthcare in the United States, one of the key economic engines is elective surgeries and procedures, right? Because it was, and I think people think elective and they think, oh, that's like, cosmetic procedures or things like that. But it's a whole host of things. It's screening colonoscopies and screening endoscopies, and it's repairs, it's biopsies. I mean, the category of elective is so broad, and I think you lose some of the, you kind of connote it with something that's extremely discretionary or like plastic surgery, but that's really not the case. And what we saw is that the shutdowns and then the either in some cases self-imposed or county or state restrictions on doing elective surgeries, that had a profound economic impact on organizations. And what that shows is that elective surgeries, particularly in the hospital environment, particularly in the hospital outpatient environment, are a key economic engine. And that it's probably the principal economic engine in healthcare in the United States. And when that's shut down, you can see the consequences. So that small piece of business is really driving the ability to serve the entire whole. And that small piece of business, quite frankly, is under threat because the hospital environment is probably not the most cost-effective place to provide that care. So I think that's one thing that became very, very apparent sort of from a face validity standpoint with respect to our business model. The second aspect of our business model, sort of the dirty secret that everybody knows in healthcare, is this issue of cross-subsidization. And that is that in general, in not-for-profit healthcare, that organizations cross-subsidize the losses in their government payers with the margin they generate from their commercial business. And this cross-subsidization has been going on for quite some time. And I think that the challenge with this business model is two or threefold. And there was a great study put out by Rand last fall, covered by
think we've lost Rishi for a moment. Let me just see if,
Commercial margin is offsetting the losses in government reimbursement. And the challenge is that commercial margin is decreasing. That commercial margin is decreasing because of the rate of inflation within healthcare versus the rate of revenue increase. And that government loss base is increasing as well. So that's really, I think, one of the other challenges to the business model is that the cross-subsidization piece is no longer working. Quite frankly, the public doesn't like the idea, and employers don't like the idea of cross-subsidization because they feel they're paying more than they should, even though the idea of cross-subsidization it's a very common idea in other industries, in other businesses. I won't speak about insurance, but for instance, in telecom, the losses in providing cell service in rural markets, those losses are offset by the margin that is generated in denser markets. But it's clear that I think employers and the public at large are very much against this idea of cross-subsidization. And that's going to prove to be a big challenge that needs to be resolved.
I think we also find, hospitals tend to be sort of some of the largest employers in their communities. So having gone through this significantly challenging financial year, not only financially, of course, but what is the impact on the ultimate communities as a result of some of this financial hardship?
Yeah, I always like to think that, in not-for-profit healthcare, that not-for-profit piece, that's a gift that has been bestowed on the community. The gift being our tax-exempt status in return for something. And I like to also think that it almost creates like a fiduciary obligation in the way that a for-profit firm has an obligation to a shareholder. But I like to think about that analogously, that gift from the community does create an obligation. I do think that obligation to the community is principally in the form of high quality care that is affordable and that people can get to in that regard. And certainly there is probably a component, though I would probably put that secondary, about the impact that we have on employment in the communities. I think fundamentally, Kim, we have to have a change in the business model that exists within not-for-profit healthcare. And in my opinion, I think when you look at those losses on the government side of the business, Medicare and Medicaid, probably the way to change our business model is to go towards more away from that fee-for-service construct, which is very transactional and on a per unit basis is fairly, does not cover our costs, but to move from that type of model in Medicare and Medicaid to more prepaid care, more capitation, more first dollar risk in Medicare and Medicaid. Now, that could take the form of taking capitation. It could take the form for organizations of having your own health plan. It could take the form of having more Medicare Advantage lives. It could take the form of being in Medicare shared savings programs or direct contracting for Medicare. But, the underlying impact is not going to be changed until we actually change the business model. And I think probably the key part of the business model to work on is in the government reimbursement side of things. I think that's going to be our ability to sustain and continue to serve communities.
And I would actually think with your specific to Sutter and your involvement in population health, that's actually put you in quite good stead
I don't know if it's put me in good stead. It's definitely put me in the target for being responsible or accountable, or one of them. And the thing is that certainly our work in population health has been designed to have an approach that has high quality and appropriate utilization amongst these capitated or prepaid care populations. The thing though that we talked a little bit about this before when we were planning this out, is that the healthcare we deliver maybe only accounts for 20 to 30% of the impact on somebody's overall health. And so much of their overall health depends on their environment, their living circumstances, their work circumstances. I think people euphemistically refer to this as the social determinants of health around those ideas. But that term, again, a very broad term, and I think it's a little bit of a euphemism, it masks a variety of really tough things for us to talk about. It masks ideas about hunger, food insecurity, difficulty with transportation for work or for getting to medical care, employment difficulty, housing difficulty. So, this sort of field of population health, there's certainly some things that we can really work on about improving quality, trying to avoid emergency room visits or avoid unnecessary hospitalizations. But there's this other bigger swath that is even probably more significant to a person's health, that we, going back to those ideas earlier, we will need to partner and work with others to be able to have the impact if we're going to really improve care in populations.
And I think this is sort of the whole term we've been hearing a lot about is health equity and not just health care. I know that was a common theme that came out of the JP Morgan conference at the beginning of the year.
Yeah, that I think it very much ties into the ideas of health equity. And it's actually an area that Sutter has been pretty progressive and has done quite a bit of work at looking at how outcomes are different for different diseases in different populations that we serve. But it's not enough to say, well, the differences exist. I think the next question is, what are we going to do? And in some cases, I think that's an opportunity for us as an organization to directly intervene. There's an opportunity for us as an organization to partner with others to intervene, or to fund others who are in a better position and, quite honestly, in a better trusting relationship with the community to be able to intervene. A great example is, we identified in our health equity work a significant disparity in ER visits and hospitalizations amongst the African American population with asthma in Oakland, in the East Bay. Again, the analysis and the work identified that health equity issue, that disparity. Then the question is, what are we going to do about it? And what we did about it is we partnered with a community organization and have brought a respiratory therapist into the community to improve medication usage, controller medication usage, and that partnership, I think, bringing clinical care to the streets, so to speak, or on the ground to where people are, has actually has led to better care and decreased ER visits for asthma in the population. So that's been a great win on those ideas of health equity. But certainly it's an area where we can all, I think, collectively understand more and do more.
Let's switch gears a little bit now towards leadership. Our leaders have been severely tested, no matter what industry. I think we all have. But one thing that seems very clear is that it's almost the line between personal and professional is now very blurred post-COVID. I'm just wondering if you could touch on that, just in the context of leadership.
Yeah, I was always, I would say 2 years ago and more, I was always a leader who tried to keep the professional and the personal very separate. I kept it very separate. And I realized, Kim, that that was a cop-out on my part. And it was a cop-out because I was keeping it separate because I thought that if somehow I was personally connected to the people I worked with or had that personal connection, that would inhibit my ability to ensure their accountability or to make tough decisions that impacted them when necessary. And I say it was a little bit of a cop-out because what I realized as I reflected on my experience is that that personal connection we have with each other, that's actually the basis of resilience and strength. I think about another really challenging and tough time in my career when I worked in the emergency rooms. And I've always worked exclusively in level 1 urban trauma centers. And those are really super stressful environments. But when I think about how it all came together and why those teams worked because of the personal connections we had amongst each other. We were almost like a family. The doctors, the nurses, the techs, we would go out for drinks afterwards. We would hang out afterwards. That personal connection was the basis of our resilience to get through hard shifts and very tough cases. That personal connection was the basis for us being a high functioning team. So I started to realize a little bit before the pandemic that, my drawing this line between personal and professional was not only not consistent with my previous experience about resilience and what it takes to have high performing teams, it was a cop out on my part. You realize during the pandemic that you couldn't draw these lines between personal and professional, right? Your work colleagues and your peers, we were all dealing with not just all the challenges of the pandemic, but there's virtual school. Who's going to take care of the kids? You've got family members that are in distress and that are isolated. You've got family members or people with mental health issues. You'd be on a Zoom call and you'd hear. I was on Zoom calls and people heard, my kids yelling at each other, or my wife yelling at my kids, and the dog going crazy, and there was no boundary between the personal and professional. But that intermixing, which I know was perhaps not part of my leadership style historically, that's how we actually have resilience. That is, I think, one of the keys to resilience. Connections between people, community and sharing between people, relationships between people that aren't just work related. That's how you build, I think, resilience. When the protest movement happened last summer around, precipitated around the George Floyd killing and Black Lives Matter, that was another example. You couldn't leave that when you came to work. You had to bring that. That people were bringing that in. Again, that's that, I think, blurring between the personal and professional. I would encourage folks to see that as a basis for resilience and a new model of leadership that we need.
I think not just in healthcare. I would echo that.
Kim, we don't have any questions coming in unless I've missed
them. Just double checking again. Nope, no questions currently, but please, if anybody does, just submit them through the Q&A function. We'd be happy to address them. One of the other things, obviously we're speaking a lot about COVID. Prior to COVID, many of our renewal meetings we'd be talking about quality patient safety initiatives. We've historically spent a lot of time talking about OB. COVID has sort of taken over the headline at the moment, but our health systems are obviously still dealing with care that was delivered prior to COVID as well. Just wondering, how are you really able to help staff deal with burnout, given all the pressures that they're facing?
Yeah. I think that's, sometimes I get asked the question, what kind of keeps me up at night? What do I wake up with in the middle of the night? And I would say, Kim, I wake up thinking about people. Sometimes it's specific individuals, sometimes, and it's about the stress that these people are under. And I would say it's also just about the workforce and the tremendous stress and burden that they've borne and that they continue to bear. I think it's the number one issue that I certainly think about, and is probably one of the top issues that we should be thinking about in healthcare in general. I think there's things that we can do formally, and then there's things that we can do informally. The formal is that we have a number of resources in our organization. I know most healthcare organizations do employee assistance programs, mental health counseling, social and focus groups that have been extraordinarily well and heavily utilized by our people. And that's, I think, an extremely important part of things. The second thing, more informal, I think goes back to our previous conversation about, leadership style, and actually encouraging that blurring between professional and personal so that we build real connections, real community amongst ourselves. I think that's a really important need for resilience. I think the third piece is that we need to try to find little pockets where we can give our people respite and breaks as best we can. We had a pocket, I think, sometime in the summerish fall of last year. I think hopefully we are coming to a pocket right now where we can be very purposeful and mindful of trying to give people respites and breaks. I think that's really important because I don't think we're out of the woods yet on the pandemic. I've been wrong at every step of the way about where things are going to go or what things are going to happen. I'm not going to pretend to prognosticate the rest of 2021, but I think we got to try to give people breaks when they can, not just time off, but mentally and physically, because I think we've got still a little bit to go. And now I start to see the questions coming in.
Yeah, they are indeed. There's one, Rishi, can you comment on the approach to requiring or not requiring COVID vaccinations for all clinical staff?
Yeah.
Do you think that should be an organizational decision or a governmental regulatory decision?
Yeah, that's a great question. We certainly, as an organization, have been debating that and thinking about that. We're not quite there yet. I don't know what the county or state or federal authorities, which all have different jurisdiction levels, are going to be doing. I would like to think that the way that U.S. healthcare organizations have thought about flu vaccine could be a model, where that if you don't meet certain exceptions, then there or exceptions or accommodations, then it's a requirement. And I know there's some variation in healthcare organizations about how they treat that, but I certainly hope that would be a model for how we can think about it. Certainly there are other diseases where we require individuals to have either vaccinations or proof of titers. So I think there's a basis for us to think through this, and I hope we'll use that as the platform as opposed to reinventing the wheel.
Great. Okay. It's another interesting one. How do you see the hospital and healthcare industry rebounding post the pandemic? What risk management strategies are key in the post-pandemic environment?
Yeah, Kim, I can't see the question. Were they asking specifically rebounding financially, or is it not clear? Oh, I see the question.
Yeah, I think it's probably more with respect to risk management.
Oh, yeah. My sense is that, although we've had this sort of overwhelming focus on COVID, we've still been taking care of, particularly in our hospital and obviously in our virtual care environments, patients who have all sorts of other disease entities and problems and comorbidities. So I think that has always been continuing. I think that the challenge we're going to see from a risk management standpoint, we may not really ever quite understand this, is that there certainly has been a delay in care. A delay in preventive care, a delay in routine screenings and checkups and follow-up visits. We saw last summer, a a big bolus of some of that delay in care came to all of our organizations and sites. And I think that, I don't know if we're going to see a bolus again, because I think we've definitely seen probably a delay in care in some of these important things, but I think it's going to start to trickle back slowly over a period of time. But those delays, again, those were delays that folks decided, I think in some cases on their own, or were inhibited for whatever reason. That's going to have real impact on disease incidence, on occurrence of disease, complications, quality of life. And I think that's something that we're not going to quite understand, unfortunately, for at least another couple of years. What's the mitigation approach on that? I think the mitigation approach on that is we've got to get people back in for these important visits that are important to their health.
That's right. Okay. There's one here, more of a strategic slant to it. What is your take on the frenzy of all the M&A, IPO, and private equity funding activity in healthcare? And what is your hope for the outcome disruption in the innovation space?
Yeah, so I would say that I think that given the overall state of healthcare financials and balance sheets across the industry, whether that's in not-for-profit healthcare, medical groups, or individual physician practices, and I think there's a very significant challenge with physician practices being able to stay in independent and weather the challenges of shutdowns and the supply needs that you require. I do think that we will see over a period of time, and I don't think it's all going to play out overnight. I do think it's going to play out over a period of probably three to 5 years. We will continue to see, I think, more M&A and acquisitions and PE activity within the delivery side. I think you will definitely see more IPO and disruption, because this entire pandemic has proven out that there are other models for being able to deliver care and to be able to deliver health that do not require necessarily an in-person interaction and can have a lot of benefit and value. I think that we'll find that those individuals who come up with those solutions may partner with healthcare organizations, or they may partner directly with the payers, whether that's a fully insured health plan or whether that's a self-insured employer. So I think you will definitely see a lot of activity, because the thesis of virtual care has just been proven in the past year, the value and the ability to do it, and consumer patient receptivity.
Right. One other, do you think the pandemic will push clinicians out of the practice of medicine early? Alternatively, do you think it has inspired or encouraged others into the practice of medicine?
Yeah, I think we'll probably see a little bit of both. I think there will be some physicians, and I've heard anecdotally, who are, honestly, because of the financial strain and the financial burden that's associated with during the time of the pandemic and some of the challenges of being able to manage an independent practice. I do think that some physicians will end their practice and their careers earlier than they had thought, and I've certainly anecdotally heard about that. At the same time, I think you're going to see this entire group and generation that is inspired about being in healthcare and healthcare-related professions in a way that we haven't seen before. Actually, I did catch an article, I think it was in the Wall Street Journal a day or two ago, that was a record number of applications to medical school in the past year. So I'm hoping we'll see that in medical schools, nursing schools, tech programs, CLS, pharmacy, the whole thing. I think we're going to see that in a significant kind of way.
Right. We've talked a lot today about sort of hospitals, health systems. We also have a question just how different parts of the country responded to the pandemic, as well as sort of in the long-term care industry. I don't know whether you have any specific comment on that.
Yeah, so I think that was something the pandemic exposed, was a significant vulnerability within the long-term care space. with respect to being able to have the infrastructure, the equipment, and the staffing and the training to be able to care for an extraordinarily infectious disease during this time. I think it was twofold, that they had limited ability to be able to accept patients in those environments. We, I think, all heard about the significant contagion that occurred within these environments, particularly earlier on in the pandemic, and difficulty with the personnel and infrastructure support that was required. In some cases, at least I think in our geographies, the county and the state had to help significantly to be able to stabilize some of that. I'm speaking in particular in terms of skilled nursing facilities, to be able to enable that. It is such a critical point within our healthcare system. It probably gets overlooked, and I think there's going to need to be a systemic need for more investment and more resourcing in there. It did prove to be a vulnerability, I think, during the pandemic overall.
Okay. We're coming up on time. I think, really to sort of conclude, thank you, Rishi. One thing's clear, that it has, and unfortunately continues to be, a painful journey for everyone right now, without exception. COVID has really made us question how we've done things. It's highlighted socioeconomic health disparity, but it really has been an accelerant for change. And, we look forward to seeing how that is going to impact healthcare delivery in the future. I really would like to give a special thank you to Rishi and the Sutter team, and quite honestly to all of our healthcare systems who continue to be on the front line of this pandemic. We really appreciate all you do. Well, we are hoping, and I would actually ask that you mark your calendars for the Bermuda Healthcare Forum live and in person in April 27th and 28th of 2022. We are really hoping that the third time is a charm. Thank you, everybody, for joining us today. And we look forward to continuing. I guess there'll be more of our virtual meetings as we go forward. And if there are any other questions that come through, please feel free to reach out to any one of us. And as I said, we will be distributing the presentation following. Thank you.
Thank you so much, Kim.
Thank you.